Hello, I'm Dr. Yazdani. I work in emergency medicine. If you're a junior doctor with an interest in emergency medicine, stay here. You will receive a lot of elderly fallen patients in your emergency department. Knowing how to work these patients up is an important skill. You'd be better off treating every faller like a mini trauma call, the ABCD approach, This way, you're less likely to miss important stuff. Once you're sure your patient is stable, you can start investigating the cause of the fall. People may fall for different reasons. Most commonly, they lose balance. I'm sure you've heard of these referred to as mechanical falls. Most fallers happen to be the elderly, people who for one reason or another may not be able to tell you if they had chest pain, breathing difficulty, dizziness, or loss of power before the fall. History. It's ideal to be present for the ambulance crew handover to hear the story firsthand and ask any questions you may have. Believe me, this makes life so much easier. If this is a patient you're picking up somewhere down the queue, chances are you'll have to rely on the crew's written script, which if handwritten may be harder to read. But don't worry, the patient has been handed over to one of our nursing colleagues. You may be able to talk to them, assuming the patient is not able to give you a good history or any history at all. Call the patient's next of kin or the nursing home they come from. Time-consuming? Yes, but often worth it. Be extra careful with unwitnessed fallers and those who've been on the floor for an unknown period of time. If there is any mention of falling from a height, like a flight of stairs, make sure you have fulfilled the basic ATLS principles before proceeding. All of this assumes the patient has not already been trauma called. If a patient has waited 2 hours to be seen after triage, it doesn't mean it's too late to put out a trauma call once you've learned more about the mechanism of injury. There are many checks and balances in place, but remember, at the end of the day, it's your call. I never forget the case of a walking patient with learning disabilities and a vague history of a car involved in the accident. This one had somehow slipped through the triage net, but was quickly picked up by a colleague who then put out a trauma call and treated the patient for significant injuries. Always assume head and neck injury in a patient who is confused, nonverbal, or distracted by pain. Immobilize such patients immediately. Remember to ask if the patient is anticoagulated. Many of them are, and requesting a brain CT within the first hour may mean the difference of life and death or disability. If your patient is going for a brain CT and you don't think you'll ever be able to clinically clear the neck, it's often considered pragmatic to scan the head and C-spine together, particularly in the elderly. Now let's move on to physical examination. Don't forget to obtain consent where applicable. Inspect the patient from head to toe. You don't want to miss that occipital wound, that bruise on the chest or abdomen, or that thigh deformity. Missing a deformed shoulder in a hemiparetic patient is particularly bad. Listen to the chest and abdomen, but also learn to use ultrasound as an extension of your physical examination skills. You may not hear those crackles in your busy department, but you may be able to see those B-lines easily, suggesting overload. Pleural effusions are particularly visible on ultrasound. See the heart in action. Don't even try to exclude anything if your skills are limited, but try to pick up significant pathology like free fluid in the abdomen and cardiac tamponade. Don't skip palpation. This may be the only clue to finding a femoral shaft or a scaphoid fracture. Pain thresholds are variable among patients. Some only grimace, others may scream. In summary, document your examination of A, airway and C-spine, B, breathing, C, circulation, D, neurology and blood sugar, and E, exposure. And now on to investigations. Read the patient's vital signs. Especially pay attention to the first set of vital signs recorded by the ambulance crew. I often find the body temperature recorded by the ambulance crew most useful. The clue to that pulmonary embolism, urinary infection, or incipient sepsis may lie in those first readings, which may now have normalized thanks to the first responders. Get an ECG. Make sure there are no acute ischemic changes or critical arrhythmia. If the rhythm is irregular, try to find out if it's new or old. If old, is the patient anticoagulated? If so, has there been a head injury? New onset arrhythmia may even have more significant implications. Get that blood gas or point of care reading. Spotting a critical electrolyte derangement early may save your patient's life. Again, this reminds me of an interesting case I'll talk about in a different episode. The ambulance crew often beat us in checking the blood sugar, but double check, it won't hurt. Is the pH too low or too high? Is the patient hypoxic or retaining CO2? Have they been exposed to carbon monoxide? Is the methemoglobin too high? What's the lactate reading? And if you're lucky, what's the creatinine clearance? Assuming your patient is well enough to stand, do they have a postural BP drop that could have led to their fall? Orthostatic hypotension is usually a reliable and early indicator of hemodynamic compromise. Getting a urine sample from your patient may not be easy. Going past urine infections, you may want to know in a young female patient if they are pregnant. Today, of course, it's more about the elderly. Use your local guidelines in getting imaging. What I have noticed is that the threshold for getting CT scans has come down compared to, say, 5 years ago. This is in part driven by the fear of missing occult intracranial, spinal, or internal organ injuries, especially in the elderly. As a rule of thumb, if you find an injury that suggests a catastrophic mechanism, seriously consider immobilizing the patient on a trauma mattress for full trauma series. Follow your local guidelines, which are often guided by common sense. You may find getting CTs in some institutions is more strict than in others. I talked about C-spine earlier. If the patient doesn't already qualify for a full trauma scan, use your local guidelines to get brain and C-spine CTs where appropriate. Chest X-rays are invaluable sources of information. I'm not remotely suggesting getting one for every patient who walks through the door, but request them where rationally indicated. For instance, getting a chest film for a fallen patient on warfarin who's complaining of chest pain is a no-brainer. You may or may not spot other pathologies on a chest film that may have contributed to the fall. Again, a reminder, we're assuming this is not a trauma call scenario. If your patient's leg appears shortened or rotated, or if they complain of pelvic pain, make sure a pelvic film is in order. Neck of femur and pubic ramus fractures are common in the elderly fallers. You don't want to miss one. Request limb x-rays if you have reasonable suspicion. If you find a fracture, you'll need to x-ray up to one joint above and one below. Some fractures come in a package, like the famous Mason-New fractures. So if you find a proximal fibular fracture, for example, look for an ankle fracture next. Getting your C-spine right is critical for obvious reasons, but catching thoracolumbar spine injuries may not be less significant. The most famous example is a patient who has jumped and is now found to have a calcaneal fracture. This patient qualifies for comprehensive spine imaging due to the suggestion of the significance of the axial load during injury. This, of course, is usually a young patient and not the topic of our talk today. I tried to be systematic and focused, but being an emergency doc is such a diverse and analog experience. You sometimes forget that you're just rambling on. Please subscribe and share this with your colleagues if you liked it. And thank you for watching.